So again, a very warm welcome to this ESH-iCMLf conversation that is going over the highlights of the ESH-iCMLf 26th Annual John Goldman Conference on CML, Biology and Therapy. So we are delighted to once again have our two co-chairs, so Professor Daniela Kraus and Jorge Cortes, who'll be giving these highlights. So again, wherever you are in the world, a very warm welcome. We're going to start with the clinical overview by Professor Jorge Cortes. Now, I will just give a brief overview for those joining us for maybe the first time. So Professor Cortes is the director of the Georgia Cancer Center in Augusta. And before joining this center, he spent 23 years at the University of Texas MD Anderson Center in Houston, most recently as professor of medicine and deputy chair of the Department of Leukemia, where he directed both the CML and AML program. Professor Cortes is the principal investigator of many of the key CML trials over the past decades and has authored and co-authored nearly 1,000 peer-reviewed articles during his career. Current clinical interest focuses on new drug development, predictive models, reducing toxicities of cancer therapy, and improving quality of life for patients with leukemia. So Professor Cortes is both the chair of the ESH-iCMLf and the annual John Goldman Conference, and he will share the clinical overview today. Thank you, Jorge.
Thank you very much, Nicola, and thank you everybody for joining us. It is a pleasure to talk to you about some of the highlights in this meeting. And I will start by saying that this year we had an outstanding meeting. We had more than 380 people attending. We had great presentations, highly interactive. It was really a very enjoyable meeting. And I think there was a lot of new data that was presented, and we're going to try to summarize. It's very difficult to summarize everything that was presented. There was really a lot of very good information. So anything I don't discuss here, it's not because it was not relevant. It's just because of the limited time that we have. But I wanted to mention a few studies that I think are very valuable and that may even have some important implications today in our practice. As it's traditional in this conference, we start with the abstracts that receive the highest score during the review process. And there are three there in clinical studies that I want to mention in this presentation. Two of them relate to the effect that the pre-existent mutations in other cancer-related genes have on the response to therapy, and specifically to frontline therapy. So as we know, there's a significant number of patients, probably about 10–15% of patients that have mutations in other genes, most frequently ASXL1. And it's been reported that patients that have these mutations at the time of diagnosis have a worse outcome. They have a lower probability of achieving a response. They have a higher tendency for progression eventually. Most of the data had been generated from previous studies and sometimes in small cohorts and so on. What we had in this study was, one, it was a study that was coming from Adelaide, where Susan Branford analyzed from patients that had been treated in different studies in their Australian comparative group. Some studies had used imatinib, their Tidal approach, starting with higher doses and then advancing to nilotinib when the patient didn't meet the desired endpoints. And then other patients had been treated with second-generation TKI. So these were historical studies. These studies have been reported, and we know the endpoints. However, they had stored samples and they analyzed the presence of these mutations. And the question was whether using a second-generation TKI could overcome the adverse outcome expected by the presence of these mutations. And what Sue Branford presented was that unfortunately, particularly for the patients that have an ASXL1 mutation, the outcome remains poor in these patients. So it is very important then to know these, because obviously these patients, we need to pay close attention. And I'll comment more about these, but let me discuss then the other study, because it's in a similar setting. This study comes from Germany. It was presented by Thomas Ernst from Jena, and he analyzed the data that was done on this study that's called the Fascination study, where they used the Asciminib in combination with a conventional ATP competitive tyrosine kinase inhibitor. Again, the results of the overall study have been reported, but the question again here was whether these mutations still had a poor outcome when we used the newest tyrosine kinase inhibitor with a different mechanism of action, a myristoyl pocket inhibitor, Asciminib, and in this particular study, actually in combination with an ATP competitive inhibitor. And what Thomas showed was that the outcome of these patients with these myristoyl pocket, with these mutations, particularly the patients with ASXL1, which is the most common of these mutations, was poor. So this is important because evidently we need to look at better ways to manage these patients. Now, we need to keep in mind that although both studies showed that the outcome was inferior, most patients still do well. So I don't think we are at a point where we would say that all these patients would have to be transplanted or something at the time of diagnosis. These patients just needs to be monitored carefully, but many patients will still respond well. It is just something important to keep in mind and follow up on this population, and if they're not responding well, then perhaps today consideration of transplant may be earlier than in other settings. But I don't think that we would skip the use of a tyrosine kinase inhibitor, even a second-generation TKI nowadays, perhaps even Asciminib, if it gets approved as frontline therapy. Another clinical study that was presented in these top scoring abstracts was a very interesting study, and this was presented by Kendra Sweet. It is a multi-center study. It's conducted with this conglomerate in the US that's called SWOG, Southwest Oncology Group. That includes multiple institutions. And the main principle of this study was that, as we know, many of the patients that we treat with tyrosine kinase inhibitors, they do well, but they don't get the goals to be eligible to consider treatment discontinuation. And there is some preclinical data to suggest that these leukemic stem cells that are residual, that are persistent, that are not eliminated by tyrosine kinase inhibitors, are very sensitive to a JAK2 inhibition, and that in vitro, when you combine a tyrosine kinase inhibitor with a JAK2 inhibitor, you can now induce apoptosis and reduce, if not eliminate, these earlier progenitors. So the concept was, if we have patients that have been receiving therapy with a tyrosine kinase inhibitor that have been doing well, but not quite to the point of meeting the goals for treatment discontinuation, can we add ruxolitinib, a JAK2 inhibitor, and would that allow more patients to reach those criteria? So it was a randomized study for patients precisely as I described, patients that had achieved a complete cytogenetic response, but not a MR4.5. They had been receiving therapy with a tyrosine kinase inhibitor. It could have been any of the approved frontline inhibitors. either imatinib or a second-generation TKI for at least a year, and they were randomized to continue their TKI or to add ruxolitinib to these therapy. The primary endpoint was the achievement of MR 4.5 at 12 months, and there was a very large difference in favor of the addition of ruxolitinib. The MR 4.5 rate was 14% with the combination compared to 3% with the TKI alone. So only a minority of patients achieved that goal. So that's important to recognize. Again, it was 14%, but it is significantly more than patients that continued with the TKI alone. They also presented the MR4 rate, and that was also almost double, 46% versus 26% by 12 months. Now, MR4 is a very valuable response. Some criteria for treatment discontinuation use MR4 as a criterion. That's still perhaps a little bit controversial, so I'm not going to get into that. But the point is that you do get many more patients to get to these goals if you add ruxolitinib. The treatment, the safety profile that they presented was quite acceptable, more myelosuppression, as you would imagine, but very little of that was grade 3. Also, some more GI toxicity, some more fatigue, some more liver toxicity, but mostly grade 1 or grade 2. So a very, very interesting study, and this was randomized. So I think it carries some value. Now, where do we take this? I mean, do we use this in the clinic or not? I don't think this is quite to that point that we would do it on everybody, but it may give us a hint as to the things that we may need to do to increase the rate of achievement of criteria for treatment discontinuation in these patients. Let me move now to another study that I found very interesting on this in this meeting, which was a propensity score analysis of Ponatinib versus Asciminib. We know that these two drugs are very good, very valuable for patients who have received 2 or more tyrosine kinase inhibitors or who have a T359 mutation. And they're both approved and available in many countries. We are trying to define, is one better than the other? They've never been compared head to head. So trying to understand the pros and cons for each one of these drugs. So what Dennis Kim, who presented these, Dennis is from Toronto, from the Princess Margaret, but he collaborated from investigators from 10 countries all over the world, from Europe, from Asia, from Latin America, and collected more than 600 patients that had been treated with Asciminib or Ponatinib, about half and half, grossly 300 with each one of these drugs, and then matched them as much as possible by characteristics such as the reason for discontinuation and their age and other factors. With the propensity score matching, he ended up with about half of the population, 270 patients, and they matched, I think, reasonably well. But what these analyses then showed was that the outcome of patients with Asciminib seemed to be better. He presented the event-free survival, and he presented the probability of having an event, so lack of efficacy or progression to more advanced stage or discontinuation due to adverse events. So there seems to be a trend for better outcomes with Asciminib. Obviously this is a retrospective analysis. There's many areas where we could question how to understand these, and it doesn't mean that we wouldn't use a drug both drugs, as I mentioned at the beginning, are very, very valuable. But it gives us some hints as to some of the values of these drugs. One thing that I should have mentioned is that he found that failure to Asciminib was more frequently due to resistance, whereas failure to Ponatinib was more frequently due to intolerance. So that may be part of that difference that was identified. So an interesting analysis that helps us understand better these drugs. There were also some interesting reports on some of the newer drugs that are coming. I'll start by one this is one that I presented, and this was the final analysis of Asciminib for patients with T359 mutation. As we know, Asciminib, as I mentioned, is a myristoyl pocket inhibitor, very valuable in patients that have 2 or more tyrosine kinase inhibitors, but also in patients with T359 mutation. We know that in this indication, we use it at higher doses. And we have seen the initial report was recently published of this drug in patients with T359 mutations. Well, here we presented the final analysis when all patients had been followed by for at least 5 years. So the median duration of exposure was about 3.5 years. Everybody had been followed for at least 5 years or had come off study. And although the initial report had showed a rate of MMR of 42%, with continued treatment, the rate continues to improve. So it reaches about 53% by 264 weeks. And then it reaches a plateau. And then we had also seen that the response rate is better for patients that have not been exposed to Ponatinib. That remains the same. But the rates continue to improve. Actually, for patients who have not received Ponatinib previously, the rate goes all the way to 73%, whereas for patients who had received prior Ponatinib, it's 38%. And there's also the very interesting MR4s and MR4.5s at around 30% each. So very valuable responses. One thing that we presented here was also what happens of patients that received a lower dose. And patients that received 150 or 160 twice a day, but still, they're small numbers, but there were still good responses in that context. However, patients that received 80 milligrams twice a day or less, then the response rate really drops more significantly. So again, supporting the need for a higher dose in this patient population. So a good analysis just to show the long-term follow-up. I'll finish with a couple of studies with some of the newer drugs that are coming. One of them is the Olveraimbatinib. Olveraimbatinib is a drug that's been approved in China, and but there are studies being conducted all over the world. And one of these studies was presented here. This was an analysis of Olveraimbatinib in patients with 2 or more prior TKIs or with T359 mutation, exploring 3 different doses, 30 milligrams, 40 milligrams, or 50 milligrams twice daily. This study showed or confirmed the data that we had seen from the studies in China with rates of major molecular response of about 40%, with very similar response rates for patients with or without T359 mutation, really almost identical results. Also very good data for patients whether they were resistant or intolerant, very good data whether the patients had received Ponatinib or not. So the patients exposed to Ponatinib, they had a 36% response rate, very good safety profile, very few adverse events, no arterial occlusive events. The most common toxicity that's interesting with this drug is skin toxicity. Freckles are very common with this drug. So a very valuable drug, and this drug is undergoing a randomized study, a global study to see if it can get to approval. The other drug that was presented, this is earlier, is the Enliven drug ELVN-001. And this is another drug that has good activity against all mutants, including T359. It's a competitive inhibitor, but it has very high activity in vitro in preclinical work against all the different mutants, both the conventional ones as well as the myristoyl pocket mutants. So this was the early results of a phase 1 study. There were 39 patients that were reported. Importantly, there was no grade 3 or 4 toxicity reported, and there was a 44% response rate. Response meaning major molecular response in these patients by week 24. So very good responses with this drug. Again, early, but it's encouraging to see a new drug emerging. And yes, we have many TKIs, but I think that good drugs are always welcome. I will conclude with just one study in blast phase that was presented. This one was presented by Philippe Rousselot and the French consortium. They presented a study of Ponatinib and azacitidine for patients with blast phase. In this study, they used Ponatinib at a starting dose of 45 milligrams, and once they responded, they lowered the dose to 30 and then to 15 milligrams daily. It's a small study, 19 patients, but they reported a reasonable response rate here with a significant number of patients achieving a good response, hematologic response in almost 80% of the patients, and with good molecular responses. The survival at 2 years is 65%, so very good. Encouraging data, again, a small study. We know we need better therapies for patients with blast phase, and this may be a good trend. And they also showed that it's very well tolerated, so that's also good, particularly for patients that may be frail or not able to take more intensive chemotherapy. So I'm going to stop here. There's many more studies, but I wanted to highlight some of these. But I want to give Danielle enough time because there were also outstanding studies from the biology part of the meeting that she was going to tell us about.
Thank you, Jorge. Yes, it's always very challenging to condense the meeting into key highlights. But yes, so I'll also move on to Professor Kraus, and we can answer any questions that the audience may have in the Q&A afterwards.